So I'm going to talk about brachial plexus imaging and the imaging modalities that are there. As you know, the brachial plexus, it's formed by the ventral rami of C5 to D1 nerve roots, and it divides into trunks, divisions, cords, and peripheral nerves. We'll have a look at the role of imaging, the types of injuries, imaging modalities, and stretch upon MRI protocol, how we do it, how do we report these scans, and the spectrum of MR imaging findings in preganglionic and postganglionic injuries. It is caused by traction of head during delivery, and most are mild stretch injuries which would heal with complete recovery. The permanent palsies are the ones that require operative treatment. Preoperative MR imaging is typically performed around 4 months of age, and MR is mainly for prognostication of injury, medico-legal purposes, and it helps to plan the surgical management. Now, imaging is directed to determine whether it's a preganglionic injury or it's a postganglionic injury, because that's what determines management. So preganglionic injury, as you can see here, there's the ventral and the dorsal rami. This is dorsal ganglion. So the preganglionic part, intraspinal part, comprises the preganglionic injury. The nerve root avulsions, there in which there is a loss of connection with the central cell body or the spinal cord, and these are the most severe form of injuries. It involves nerve rupture, wherein there is complete break in the nerve. The other postganglionic injuries are neuromas and neuropraxias, which are nerve injuries in continuity. So the imaging modalities that we have are chest X-ray, the conventional X-rays. The most important are the ones to identify fractures, clavicle fractures. Preoperative chest X-rays are important to identify the raised dome of diaphragm, that is whenever diaphragmatic palsies are present. It can be associated with C4 or phrenic nerve lesions. It's important before surgeries because if not detected, this can give rise to post-operative respiratory problems, especially when intercostal nerve transfers are considered. And this is relevant for older patients where serial radiographs of shoulder for long-term follow-up to assess osseous deformities of glenoid fossa and humeral head. CT myelography was considered as the most reliable imaging modality for preganglionic injuries. As you can compare, these MR and CT myelography images are very comparable, and you can see the nerve root avulsion on the affected side, and these are the nerve roots on the contralateral side. Another example of comparison of an MR with a CT myelography, wherein there is a defect in the spinal cord at the site of avulsion within the cord. But CT myelography can evaluate only preganglionic injuries. It cannot evaluate the postganglionic brachial plexus. That's a limitation. Besides that, it will require anesthesia, intrathecal contrast, and since it's CT, there'll be radiation. And it's known to cause false positive and false negative results. This brings us to MR, which is now the imaging investigation of choice. It allows the lesion differentiation between pre- and postganglionic injuries. MR myelography, it's a non-invasive tool for detection of pseudomeningoceles, and it's non-invasive and there is no risk of radiation. So our MR protocol, we use a 3T scanner. Patient is in supine position, mild sedation is given, and it's in a head coil. Now, each MR sequence is meant for systematic evaluation of intraspinal and the extraspinal structures. For intraspinal imaging, we start with the cord evaluation. We move on to the nerve roots. In extraspinal imaging, we look at the postganglionic exiting roots, trunks, divisions, and cords. And this is a limitation that the intraforaminal part cannot be directly and nicely evaluated on MR. Let's have a look at each part. So we begin with the spinal cord evaluation. At a glance, we can have a look at the spinal cord on T2 sagittal images. If there is an abnormality, we correlate it on the T2 axial images. On T2s, we can identify edema or myelomalacia, which is seen as a bright signal. If there is a contusion, it can be dark or it can show variable signal depending upon the blood products. And if there is a suspicion of contusion, we take an additional T1 sagittal weighted images because the hemorrhage will be bright on T1. How you identify the T2 and the T1s is T2s have bright CSF, whereas T1 has dark CSF. Now, evaluation of the intraspinal nerve roots. MR myelogram, it can give an excellent depiction of pseudomeningoceles, which are CSF outpouchings at a glance. And for detailed evaluation, to assess axial, which are nothing but heavily images, and we see these and the dorsal rami coming out of the spinal cord, uniting and exiting the neural foramina against the background of bright CSF. We can also detect pseudomeningoceles, the site and extent in this particular sequence. And this is the sequence you use to identify the nerve root avulsions. So let's have a look at one of the cases where we see sequentially from superior to inferior and trace our nerve roots. You keep an eye on the contralateral side to identify the normal ones, and we can see that there are missing exiting nerve roots on the affected side. We are going from C5 towards D1. We can see that pseudomeningocele there at C7 and C8 levels, and then there are these D1 nerve roots which are intact. So this is what we put on our films and label the relevant images. This is a large set of images that are required, but we label the relevant images and put it. So there is the C5 nerve root avulsion, C6 avulsion, C7, C8 with associated intact. This is what we put on our reports, that is preganglionic nerve root, root avulsions and pseudomeningocele from C5 to C8, and D1 root is intact. Now we move on to evaluation of the postganglionic nerve roots. So postganglionic nerve roots, at glance, we see the stir coronal images. Here we can identify the entire brachial plexus at glance, and we can compare the affected side with the contralateral side for its size, signal intensity. Also look for denervation edema, which is an indirect sign of nerve root avulsions. And for detailed evaluation, we see the T2 sagittal images, where we trace the brachial plexus from the midline towards the axilla and in the interscalene costoclavicular spaces. So let's have a look at this particular scroll. So we start from the vertebral bodies. We can see all these exiting nerve roots coming from the neural foramina in the interscalene triangle, uniting, forming upper trunks, divisions, and then again cords. That is this lateral posterior and the medial cord. So that is how we trace the postganglionic nerves from the exiting nerve roots towards the cord in sagittal images. Now we'll have a look at the same case that we were seeing. We had noted that there was a C5, C6, C7 and C8 nerve root avulsions. So now we see the postganglionic part. We can identify that avulsion intraspinally. We don't really see the exiting nerve roots in the interscalene triangle. Now we see this globular tissue at the level of the trunks and divisions. That is a neuroma formation due to the retracted nerves. Now we can again see this cords uniting and towards the peripheral nerves. So this is what we put in the films, label it so it could be easily understood. We correlate these sagittal findings with the coronal ones, wherein we identify that pseudomeningocele exiting nerve roots are missing in the postganglionic region, and then there is this neuroma at the level of trunks and divisions. So that's how we complete our report. Postganglionic nerve roots were not visualized. There were avulsions at 5, 6, 7, 8. They were not visualized in the postganglionic region. And then there was this neuroma formation at the level of the trunks and divisions. This is a post-op correlation which was concordant with the MR findings. This is the post-op notes, and there were these sural nerve cable grafts that were put from C3 and C4 with upper trunk and middle trunk. Let's have a look at the spectrum of findings in preganglionic injuries. So in nerve root avulsions, there can be non-visualization of the nerve root in the spinal canal on the affected side. The contralateral normal side is a reference mark. There can be discontinuity of the nerve roots. There can be a CSF outpouching, that is pseudomeningocele formation. There can be a focal surface defect or a dent in the spinal cord from where it has avulsed at the level of the cord. Or there can be a dural defect with resultant CSF leakage. This can form a large intraspinal epidural CSF collection like this. And lastly, the denervation edema in the posterior paraspinal muscles. It's an indirect sign of nerve root avulsions. Coming to postganglionic injury, nerve ruptures. Nerve ruptures are seen as a complete defect in the postganglionic nerves. It can be associated with a neuroma. Here we can see it's associated with the proximal as well as a distal globular thickening, which is a neuroma formation. So this is the sagittal image of the same thing. You can see that there are these exiting nerve roots are coming normally. Then there is a thickened part, that's a proximal neuroma, defect, that's a nerve rupture, and then this, which is a distal stump neuroma. So this is how nerve ruptures look like. And that's what we have put in the report. The preganglionic portion was normal, which I have not shown here. And then there is a nerve rupture with a proximal and a distal neuroma. The other kind of a postganglionic injury, which is the milder form of injury, is a neuropraxia, which are stretch injuries, which are nerve injuries in continuity, and the only manifestation is thickening and increased signal intensity of the affected nerves as compared to the contralateral side. Neuromas, now as we have seen, these are post-traumatic proliferation of neural tissue in the stump of the damaged nerve. They can occur with complete as well as incomplete nerve ruptures. And it is difficult to differentiate these from post-traumatic perineural fibrosis or scar tissue investing the plexus elements. The recent advances that have occurred in brachial plexus are diffusion weighted MR neurography, which we now routinely use for all adult brachial plexus evaluation, but it's still a little future developments are required for them to be applied to pediatric population, because it's a small area, small nerves, and we don't get that kind of good resolution even on a 3 Tesla for pediatric patients. Otherwise, it's a great way to identify the postganglionic nerves. And nowadays people are started doing ultrasonography of brachial plexus. This is just evaluation of the supraclavicular plexus and towards the sternocleidomastoid. You can compare the missing roots as to the contralateral side and also demonstrate neuromas, but this is highly observer dependent. So to conclude, MR allows systematic evaluation of preganglionic and postganglionic components of brachial plexus. It provides reasonably reliable preoperative diagnosis of the type and extent of injury. MR is the investigation of choice, and it has completely replaced CT myelography. Combined use of electrodiagnosis and imaging techniques is proving increasingly useful in brachial plexus evaluation with better precision. Thank you.